Testing. Can you hear me?
Hello, sir.
Yeah.
Can we start?
Yeah.
Dr. Rose?
Hello.
Yes.
Hello all.
Yes, you can.
Hello. Hello,
Hello.
I'm Dr. Rose.
Yes, Dr. Rose.
Hello, welcome to Idea Ernad. Good evening, one and all. Today we have all gathered together, but at our own ends due to the COVID pandemic. But let us take it in an optimistic manner. We are saving resources, aren't we? So here today I'm welcoming Dr. YOHAN CHACKO. Completed his BDS from Annamalai University in 1996 and his MDS in Conservative Dentistry and Endodontics from the Tamil Nadu Dr. MGR Medical University in 2001. Apart from running a dental practice, he has been actively involved with the university teaching and continuing dental education, having conducted numerous hands-on courses in various venues across India. He is also the author of various national and international papers and has contributed towards the success of numerous national and international conferences. Hearty welcome, sir. We all are eagerly looking forward to updating our knowledge from this webinar. Sir.
Thank you, Dr. Rose. And thank you, Dr. Shah, for this invitation to share a little bit of what I know with all of you. Today's topic is about rubber dam application as well as endodontic access. And why rubber dam application? Because I think we've reached a stage in dentistry where we cannot do without rubber dams now. So whether you like it or not, you will have to learn it somehow. And there's no better time than right now. Of course, getting the resources is difficult, but if you pay attention to this particular webinar, maybe you'll get an idea of how you can start placing rubber dams. And with that, I'm going to move over to PowerPoint, and we'll have a little bit of a lecture, and then I'll come back to the screen and we'll do a live demo on how to place a rubber dam, and then we'll go back to the lecture for access opening. So, sit back and grab your cup of coffee or do whatever you want, because this is one of the most beautiful things about webinar is that the person who's speaking has no idea what you're doing, whether you are listening, whether you are sleeping, whether you are chatting with somebody else on your phone. It doesn't really matter. I think it's opened up a completely different avenue into how presentations are going to be made in the future. Here I am sitting in the comfort of my clinic in my scrubs. I would have never imagined that I would give a presentation to anybody across the state sitting like this, and here we are. So let's make the most of it, and thank you, IDA Ernad, for this invitation again. So we'll start with the nuances of the rubber dam. When you are learning anything new for the first time, you have to follow a method of scientific questioning. And scientific questioning is basically you ask, why should I do this? How should I do this? Where can I use this? And when should I start, or when is it applicable? So these are the 4 questions that come under scientific questioning that you have to apply to everything new that you learn every day. So let's apply this to rubber dams. The first thing is why? Why should I bother? Why is it important? Why can't I avoid it? Why don't I do it? Well, we'll just have a little word from the founder of rubber dams, Dr. Barnum. And he said the most time-consuming aspect about the rubber dam is the time required to convince a dentist to use it. Now that is absolutely true. For many of us, the rubber dam is an enigma because it's not one of those fundamental things that you have to learn in BDS. You don't have a test on how to place a rubber dam, so you never learn how to place a rubber dam. And you've probably seen postgraduate students somewhere over there in another wing struggling with the rubber dam for the first time. And you develop this mental block saying that I don't think I'll be able to do this. And this mental block carries on into your practice. And especially when you start practicing working with somebody else who's not using a rubber dam, and you see that person being able to do everything without the rubber dam, without a problem, then you also think that, yeah, I mean, it's really not that important, is it? So that's why the most time-consuming aspect about using the rubber dam is to convince you, the dentists, on how to use it and why you should use this. So how does it really help? Why should you be using the rubber dam? It controls moisture and splatter from the oral cavity by close to 95%. And in today's world, where everybody is scared about the air that we breathe, this is one way of making it safe for yourself and your assistants. You also have to keep them in mind. They're going to be holding the suction very close. And if by chance there is a little bit of splatter, they're going to get hit. So it is a step in minimizing splatter and protecting yourself as well as your assistants. Big question. ഇത് വാങ്ങിച്ചാല് mileage എത്ര കിട്ടുന്നത്? Yeah. How long? I mean, പൈസ കുറേ ഉണ്ടോ? And whether or not this is actually going to make sense for you in terms of economics. വാങ്ങിച്ചാല് kit വാങ്ങിച്ചാല് ഇതെല്ലാം പഠിച്ചു കഴിഞ്ഞിട്ട് can I actually apply it on a patient and still make money? Okay, which means that how much is this going to be a burden on your pocket? Very important. And I think it is a big stumbling block towards picking up rubber dams. So we will address that also. And lastly is, okay, how do I actually use this? So we will be talking about one particular method only because of the time constraints that I have. And plus, if I go through the entire thing about how to place rubber dams, it becomes a very, very boring lecture. And also, there should be something for you to find out, discover on your own. Because this world of rubber dams is not a confined space. It's pretty vast. There are many methods, there are many techniques. And my technique that I'm going to teach you today is just a starting block. It's like taking off for the 100 meters. And then after you cross 100 meters, you realize that, you can still run further. So that is up to you, how you take it further. I'm just going to give you the start. How does the rubber dam help? One of the biggest things is that it allows you better visibility because you're seeing only the tooth that you're supposed to treat, or maybe a couple of teeth forward and backward if you do quadrant isolation. But it allows you to concentrate on that tooth and improves your visibility considerably. Secondly, it reduces operator time. How is that? Because you will be saving time from asking the patient to rinse all the time. You will be saving time, worried about isolation constantly. Your mind is focused on what you have to do. There is no irrigant spill into the oral cavity. Now, you've all studied that sodium hypochlorite is a great irrigant to be used in endodontics. The reason why sodium hypochlorite is so great is that it has a huge tissue dissolving capacity. So when you put it inside the pulp chamber and the root canal space, it dissolves the tissues and destroys the microbes while it's being there. But I wonder if any of you have tasted sodium hypochlorite. When I was teaching in Savita, I used to make my postgraduate students take a little drop of sodium hypochlorite on their fingertip and then taste it. In the college where I'm teaching right now, I encourage my interns to take a drop on their fingertip and taste sodium hypochlorite. Sodium hypochlorite tastes awful. And if during irrigation, some of it spills into the oral cavity, be prepared for a violent reaction from the patient. Usually the patient will vomit on you, or the patient will kick you or slap you, or I don't know what, but it's a violent reaction. You don't want that. The rubber dam will help. No scare of a patient swallowing a file. I don't know if any one of you have had the experience of watching a patient swallow a file, sorry, not a fly, watching a patient swallow a file. It is very scary. Your heart rate will move from 75 beats per minute to about 180 beats per minute within 2 seconds. Sweat will start to come down profusely down you. And for a moment, you will be completely blank in your head, not knowing what to do. You will be staring at the patient's mouth, hoping that the file magically regurgitates, but it's not going to. It is going to stay inside. So if there is one way of preventing this file from entering the oral cavity, it is the use of the rubber dam. And finally, yes, it's an improved cross-infection control. That is a given. It also helps in you providing very predictable dentistry. Now, what do you mean by predictable dentistry? In our country, a lot of patients will come to you for treatment and ask you, what is the guarantee that you can give for your treatment? How long is this filling, or how long is this root canal, or how long is this crown going to last? What do you say? The success or failure variables are so great in our field that it is very difficult for you to give them a guarantee saying that my filling is going to last for at least 5 years. You can't do that because of the variability of science. But predictable dentistry means that in your head, you know that you have left behind a restoration which, according to the principles of good practice, should last for a considerable amount of time as long as the patient looks after it. That is predictable dentistry, and that is what you have to aim for with every treatment that you do. The rubber dam helps in improving your predictability because it improves your vision, it improves your concentration, it improves the end result of whatever you're doing under the rubber dam. It lessens your stress. When your mind is free, when your mind is not worried about what the cheek is doing, what the tongue is doing, what the spool of saliva that is hanging around just under the tongue, whether it is going to splatter out and destroy whatever you've done as far as your composite restoration is concerned. Once you are able to keep your mind free, then your stress levels reduce. And believe me, the moment your stress levels reduce, your practice improves. Your dental treatment improves. I don't need to explain how this happens. It's quite evident. This I put in, I know it's not the right thing to say, but how many times have you had a patient who wants to talk or has a doubt during treatment? It's irritating. When I finished my master's and after about 3 years, I got an opportunity to work in the Ministry of Health in Kuwait. That's when I started using rubber dams a lot, mostly because of this point, because it helped to keep the patient quiet. From the beginning of your treatment till the end of your treatment, peace of mind. You want to slip behind the patient and have a cup of coffee? You can do that, but I'm not encouraging it. So we come to this question. What is the cost benefit ratio? We'll do a simple calculation. So what I did was I went onto the web, and as of today, I just found out the cost of what a kit would be in India, what the components, individual components cost, whether you're buying Indian made components or whether you're buying foreign components. What if I have a combination of the two, Indian plus foreign? Let's come up with, we'll see what the numbers have come up with. Today, a kit made in India costs you around 11,327. This is from one company only that I've checked. But then around about, let's say, 10,000 to 12,000, you can get a range of what it's going to cost if you buy the entire kit from one company. If you buy components individually made in India, you don't have to buy from one company. You can scout around, buy different companies' components. You can make a kit for yourself for about 6,532 rupees, say 5,000 to 7,000 rupees. If you decide to mix and match, some Indian, some foreign, for about as low as 9,356, you can make yourself a rubber dam kit. Once you have bought the components of the kit, the only recurring cost is your rubber dam sheet. Definitely, the clamps also will wear out after about 3 or 4 years. But then right now, I have not taken that into consideration because of the calculations that I'm going to teach you. So the range of a rubber dam sheet costs from 650 rupees to 1,200 rupees for 36 sheets. Okay? From cheapest to most expensive that you can find on the Indian market today. So what is the cost per patient? Let's say you bought a kit for 9,356, a combination of Indian and foreign components. For 100 patients, you will need, say, 2,400 rupees for 100 sheets. So what is the cost per patient? It works out to about 118 rupees extra that you are shelling out just to place a rubber dam, as long as you've crossed your 100 patient mark. I don't think crossing a 100 patient mark in 1 year is that difficult. I don't think so. For those of us who are in practice, I think crossing 100 patients a year shouldn't be a tough target to achieve. So let's say you buy the kit on January 1st. By December 31st of that year, your cost per patient has come down to 118 rupees, assuming you've seen 100 patients in this entire year. Now let's do another calculation. Let's say instead of 100 patients, you see 300 patients. Definitely, you'll be spending a little more on the rubber dam sheets, 7,200 rupees. The cost of the kit still remains the same. But here's where there's an interesting calculation. The more patients that you do, this number that you see over here, it starts to reduce. At 300 patients, the cost is now 55 rupees extra. That is the burden on you per patient. So I don't think that it's that much of an economical burden to place a rubber dam. These are the numbers that you see in front of you. You decide. On the left side, you have 118 rupees. That is for 100 patients. On the right side, there is 55, which is the cost for 300 patients. At the end of 300 patients or 400 patients, your clamps will die out and you'll have to probably spend some money buying some clamps. If you buy some expensive clamps, then these will last you for at least 4 to 5 years without a problem. But what I want to make a point here is that the cost is not that much for you if you look at it this way. So now the thing is, how do I do this? I bought my kit. how do I do this? You need to know about what are the components that go into a rubber dam kit. The first component is the rubber dam sheet. There are many companies. Now, this is one of my favorite companies that I buy rubber dam sheets from. But there are many companies, and you really don't have to worry about which company that you start with. The important thing is that you start buying. If you really want to, experiment without buying sheets, then all you have to do is take a glove and cut out this portion, all the fingers. It opens out, and you cut one little piece from the glove, which is about this size, and that's a good enough rubber dam sheet. So to start with, even if you don't want to buy sheets, you can use your glove. We've used it in our PG time, and it was pretty effective. Yeah, we figured out how to do it. So you can have that as an option also. They come in different thicknesses: heavy, medium, and light. The difference is the stretchability of the rubber dam. Your light and medium rubber dams can stretch a bit more. Your heavy dams are pretty tight and don't stretch that much. When you start using rubber dam for the first time, I would advise you to start with either the light or the medium dam, because it's easier to manipulate. Once you start getting used to it, you can move on to the heavy dam, because most people who actually love using rubber dams swear by the heavy textured dams because they seal the tooth really well. The second component, as far as the rubber dam kit is concerned, is a template. Now, these templates usually come with a marking like this on the maxillary and the mandibular. What I would suggest is that you make 4 additional holes about 1.5 centimeters away from the center towards the tooth that you're treating. So let's say if you bisect this angle 90 degrees over here, so on a 45 degrees, 1.5 centimeters away from the center, punch 4 holes. And these 4 holes are great holes for marking single teeth. So if you're doing single tooth isolation, don't go by the markings of the quadrant isolation. Now, these markings that you see are for quadrant isolation when you want to isolate more than one tooth. That's where these markings come into play. When you want to isolate only one tooth, these are the markings that you should be looking at. The third component is the frame. There are 2 different materials by which the frame can be made. One is metal and the other is plastic. The choice between metal and plastic is purely individual. Now, you can buy metal frames really cheap. The only problem with metal frames that are really cheap is that these little extensions, metallic extensions that are on the edges of the frame, can be pretty long and pretty sharp. So one possible way to make sure that you make the rubber dam frame safe is to cut this particular end off, this particular area. If it is too long, you can cut it down to make it about 3 millimeters or so with a disc, and then with the use of a finishing burr, just rounding the edges to make it smooth. So you can buy a really cheap frame and then do that to make it safe. Now, the important thing about buying a frame is that make sure that it goes back to its original shape after you have compressed it. Some rubber dam frames are made of very cheap metal. So what happens is if you bend it like this, it remains bent. And that's a problem, because that means you won't be able to stretch the rubber dam against the patient. So do this test. It should be able to spring back to the normal shape. Plastic frames like the one that you see on the screen are quite useful because These frames allow you to fold the frame. Now, the advantage of a foldable frame is that when you want to take an X-ray for a patient and say you're treating tooth number 36 and the frame is like this over the patient's mouth, you can just fold the frame, place the X-ray inside and shoot. This frame will not interfere with the X-ray. So that's the advantage of using a plastic frame. Whether it's metal or plastic, it doesn't really matter. It's up to you. The next particular component is the rubber dam punch. Now the rubber dam punch has a circular moving portion like this over here with different holes on it marked from extra large to extra small. These holes are meant for the particular tooth that you are treating. The extra large is for the molars, the medium for the premolars, for large for the upper anteriors and canines, and small and extra small for the lower anteriors. Now this is just an indicative. You will have to tailor make this choice based on what you see. Not all teeth are really big. Molars can vary in width and size depending on gender, depending on race. So depending on what patient that you're treating and what you're actually seeing in front of you, you decide which hole you want to use. It's not a hard and fast rule that you have to follow what is on the screen over here. This is just an indicator. The next little confusing thing is the rubber dam forceps. Now the rubber dam forceps is different from your tweezer in the sense that your tweezer, your extraction forceps, all of them, as you compress, the jaws actually compress. But the rubber dam forceps, as you compress, the jaws expand. You see this? As you compress, the jaws expand. So this is a little tricky to get used to in the beginning because you're used to compression, not compression and expansion. So it will take a little while for you to get used to this movement. So that you should just keep that in mind, okay? The next component is the clamps. To start with, there are 3 basic types of clamps that you need to buy. One clamp to be used for the molars, one clamp for the premolars, and one clamp for the anteriors. With these 3 clamps, you can start your rubber dam practice. As you get better and better, you can explore the world of rubber dam clamping, buy different clamps, wings, wingless, whatever not. Now, these clamps that you see in front of you are winged clamps. These little extensions of metal that you see over here and here, here and here, and this little tongue-like extension over here and here, those are called the wings. Now, this particular technique that I have to show before you is specifically for winged clamps. Once you get better and better, you can move on to wingless clamps, especially when you're doing restorative dentistry under rubber dam. Wingless clamps become very, very helpful. So there are many ways, as I said earlier, there are many ways in which you can use the rubber dam and how to apply it onto the tooth. Now, which is the best? Anybody's guess. It's really what works for you. Whichever method you learn, don't be stuck with that method. Start exploring new methods, and finally you will find one method and you will stick to that. Make sure that you choose whichever method you choose, make sure you like that method. Today, what I'm going to show you is just one easy method, okay? One easy method. The first step is to fix the sheet to the frame. So here's the sheet over here, and I've placed the metal frame over it, and I've marked one point as the A A stands for anchor. I hold this point, I fold the rubber dam over this particular portion of the frame, I pinch it, and then I stretch the rubber dam across and release it over here, and it gets stuck onto this side. That's the first step. Then what you have to do is, still holding on to the anchor, pull to the diagonal and attach the diagonal, and then finally the fourth corner. So the rubber dam is actually attached to only the four corners, not the center pieces that you see over here. These little extensions in the center, make sure the rubber dam does not get hooked onto that right now. That's for later. So going through the steps again. You've got the rubber dam sheet, you place the frame on top, you pinch one corner, make it your anchor, stretch it across to hook the first corner, then the diagonal, and then finally the fourth corner. Once this is done, you should be able to lift the frame and the rubber dam sheet will be stuck to the frame. So that's your test. If the rubber dam sheet falls off, that means you haven't attached it to the frame that well. Step number 2 is to punch a hole off center towards the tooth being treated. So in this case, the tooth number 36, I've marked a hole which is about 1.5 centimeters away on the 45 degree from the 90 that I've drawn over here. Rough center, it's not, you don't have to be perfect. This is an approximate off center. And then you punch the hole. To begin with, it is ideal to punch more than one hole, maybe in a triangular fashion, leaving behind a little Mercedes-Benz sign over there, a triangle of holes. This is done for medium and light dams just to ensure that the dam doesn't tear as you stretch it. So you are allowed to place more than one hole in the center. Now, this particular clamp can sometimes bounce off the tooth, and if the patient swallows it, then you're in trouble. So just to make it safer, attach a piece of floss to the clamp. And how you do that is take about one forearm's length of floss, bend it in at one place into two, thread it through one of the holes on the other side, and then lock it against one of the wings. As you can see over here, it's locked. And then give it a couple of turns around the bow of the clamp. This particular curved structure is called the bow. Maybe about 6 or 7, 8, 9, 10 turns, depending on how much length of the floss you have. And then whatever comes out from this side, insert it through this hole. And this is what you do with the floss and the clamp. So lock one side and then turn it around and round and round, maybe about 6 or 7 times, and then pass it through the other hole and leave the excess outside. It really doesn't matter whether this is on the lingual side or the buccal side. I like to have the extra floss on the lingual side. If you want to have it on the buccal side, please be my guest. It's really up to you. Sometimes you may forget and start from the buccal and end up in the lingual, or start from the lingual and end up in the buccal. Doesn't matter. The important thing is that there is enough floss outside so that you can pull it if the patient swallows. That's the important thing. Step 4 is to insert the wings of the clamp into the punched hole. Now you can't do this with a wingless clamp, which is why having a winged clamp is important to this particular technique. So these are the wings. You insert one wing and then you stretch the rubber dam and insert the other wing over the rubber dam sheet. So this is what you need to do. By now, what has happened is this particular clamp is now firmly attached to the rubber dam sheet. The rubber dam sheet is firmly attached to the frame. So all these three components will actually be one. Step number 5 is to place the forceps into the holes on the clamp and expand the jaws. When you expand the jaws, these forceps have something known as a locking mechanism. Now I will just show you what happens to this locking mechanism as I expand. You can see that it comes down. Now if I release, what happens to the jaws is that it stays expanded. It does not contract again. So this is called a lock. And this is advantages over here. You place the forceps into the holes of the clamp, expand, the lock falls down, it locks into place. You can actually now lift the entire assembly. The forceps are attached to the clamp is attached to the sheet is attached to the frame. The whole thing will be in your hand. So now with the whole thing in one hand, approach the patient, and with the other hand, just identify which tooth you're going to be treating so that you know where you want to be. Then with the forceps expanded, make sure that the jaws of the clamp go around the tooth that you are treating, go all the way down to the cervical margin, and then release the lock of the clamp. The jaws will contract, you'll be able to take it out, and the clamp will be on the tooth and it will remain as such over there unless you decide to take it off. So the question is, these clamps are pointy at the cervical margin. So should you give anesthesia? Yes, you should. Every time you place a rubber dam, please make sure that you give a little bit of anesthesia to this patient, because it's not a great experience having the rubber dam clamp pinch into the gingiva. After the clamp is secured around the tooth, you take any instrument that you want. You want to take a spoon excavator, you want to take a periodontal probe, you want to take a regular probe, and release the rubber dam which is over the wings. So if you see these areas over here, you have to just make sure that the rubber dam is released on this side, and now it's sitting pretty, okay? The only problem now is that this margin over here between the jaw of the clamp and the tooth is still leaky, because ideally the rubber dam should be on the tooth and then the clamp should be there. Right now, the clamp is against the tooth, the rubber dam has slipped over the wing and it's just lying next to the clamp, but it hasn't sealed this particular area completely. So the next step is to place the forceps back into the clamp, and you do something called a rock and release. The rock and release method is when you expand only one side. So you keep one side of the clamp firmly against the tooth. The other side you expand, you allow the rubber dam material to slip up a little bit, and then you release it. Once you release it, you will find that the rubber dam goes over the tooth and then the clamp goes over the rubber dam. Now this margin is sealed very well. The same thing has to be done on the other side. So you rock one side, release, rock the other side, release. Make sure that the rubber dam material slips between the clamp and the tooth. The floss that you have attached to the clamp can be used now to floss interdentally to make sure that that margin is also sealed pretty well, and you are done. So at this point, I'm going to switch over from the PowerPoint to a live video just to show you how the same steps can be applied. So in my hand, I have patient, partially edentulous, but this particular tooth is giving him trouble and needs maybe I don't know, maybe a root canal, and I have to apply the rubber dam onto this particular tooth. I have in possession a medium thickness rubber dam, and as I said earlier, the first step is to place the frame onto the dam sheet or the other way around. Now these dam sheets, they have two sides to it. They have something called a shiny side and they have something called a dull side. Ideally, you want the dull side to face the operator, the shiny side to face the patient. The reasoning behind this is that your operator light is pretty bright, and if it shines against something very shiny inside the oral cavity, that light is going to bounce back and hit you and blind you. Not really so, but yes, the manufacturers have been good enough to give us one dull side and one shiny side. So use the shiny side against the patient, use the dull side against yourself. So I've got the dull side out over here and I've got my frame. Okay, so I've just placed the rubber dam sheet against the frame. This point is going to be my anchor point. So what I do is I just fold it over and pinch it, right? I just fold it over and pinch it. Now I stretch, 1 second. Yeah, okay. I folded it and I've pinched it, stretched and release. You will see that it gets stuck against the frame. Now I'm not actually poking this particular rubber dam into this extension of metal over here. You don't have to do that. Just stretch adequately and release and it stays over there. Now I move on to the diagonal, stretch and release, it stays over there. I hold my anchor and go on to the fourth point, stretch and release. And now my sheet is attached to the frame. Okay, so if I hold the frame like this and shake it a bit, the sheet is not falling off, which means that my attachment of the sheet to the frame is good. Next step is to punch a hole. Now, as I said earlier, you have to draw an imaginary center point. Okay, so I'm drawn an imaginary center point and I am marking a hole that I want to cut about 1 centimeter, 1.5 centimeters away from the center towards the tooth that I am treating. I take the rubber dam punch, I choose the largest hole possible and I make 1, 2, 3 holes. Okay, so I've made 3 holes. I hope you can see that. All right, so there we go. So it's 3 holes that are there and it's just made the hole a little larger than one single punch. I have my floss already attached to the clamp. You don't want to waste time on that. You already know how to do this. The next step is tricky on how to place the clamp onto the rubber dam, the hole that you've created. So this is the hole. This is the wing. Choose one wing and place it through like so. On this side, it looks like this. Just make sure you hold that wing with your hand, front and back, and then stretch the rubber dam over the other wing. I shall do this whole process once more. Slower. Watch again. I've placed one clamp, one wing. Done. I'm holding it from the front as well as the back and stretching over the other wing. And now my clamp is attached to my rubber dam sheet My rubber dam sheet is attached to my frame. Okay, sorry, I should have done it the other way. Okay, so this is how it is. My clamp is attached to my sheet is attached to my frame. So if I hold the clamp like this, then the whole thing should be one unit. Okay, so now we move on to using the forceps. Now, as I said earlier, the forceps will go into this is very difficult to do it from backwards, but anyways, all right. So you've engaged the forceps into the holes of the clamp, and now watch what happens to this particular lock. I am expanding and the lock falls. Watch again. Let's take the, I will expand and the lock falls. Now I can actually hold the whole thing with one hand. I don't have to hold the forceps from the handle anymore because of the locking mechanism. Because this is locked, the forceps is in an expanded state, and because of its expanded state, you get a frictional lock against the clamp holes. The clamp is attached to the sheet is attached to the frame. The whole thing is now in one hand. So this is something that you have to achieve, and I've showed you the steps on how to do it. The next stage is to take this entire assembly and place it on the tooth. So this is the tooth in question. You take the entire assembly, expand if required till the clamp goes all the way to the cervical margin, release this locking mechanism so that the forceps contract, and then you can take it out. So this is it. Now, as you can see, the wings of the clamp are still covered with the rubber dam. So in my hand, I have a, excuse me, I have a endodontic probe, and all I do is go underneath and release one wing, and you can see that how the rubber dam is released, and go on to the other side and do the same thing over here. Right. So the area of concern now is this portion where the clamp meets the tooth. Here, there will still be some seepage. So you want the rubber dam to actually ride up the tooth a bit. And so this is where you do the rock and release. You engage the forceps back. Oops, sorry. Right. You engage the forceps back in, release one side and rock it in, release the other side and rock it in, and you get the rubber dam to sort of squeeze through the clamp and the tooth on this side as well as that side. Your next step is to use the same floss and floss both the sides. Okay, it's very difficult to do it on the camera, I know, but then you can also use your instrument and make sure that the seal is tight around it. All right, and there you go. Now is when these little corners come into place. You stretch and release over the center points like so. And now your rubber dam placement is complete. You can work on this particular tooth, do your endodontic treatment without any fuss whatsoever. And there is no worry about saliva contamination, anything, nothing at all. To release this rubber dam, you take your forceps, place it back into the clamp, so expand it, take off the clamp, and take off the rubber dam. So this is the technique for you to learn and understand. At the end of the lecture, I will give you a link. I'm also in the habit of putting videos onto YouTube, instructional videos, and I have a channel where the same thing that I showed you today is over there, minus the flossing technique because it's an old video, and at that time I had forgotten to floss the clamp at that point in time. So do excuse me for that. But now let's get back to the presentation. Okay. So where can I use a rubber dam? In its beginning stages, it's best used for endodontics because you're treating one single tooth at a time. Really good. Learn how to do rubber dam for one particular tooth and start using it for endodontics right from access onwards. If you're worried then about visibility, then you can also complete your access and then place the rubber dam and then continue the treatment up to observation under the rubber dam. The next you can have for rubber dams, once you start with endodontics, don't start with any other form of treatment because the other methods are more complicated methods of rubber dam application. Endodontics is the simplest way to start rubber dam application because it's just one tooth. Bleaching, resin-based restorative dentistry, crown and veneer cementation, you need to know what is called quadrant isolation, where you are isolating more than one tooth. And only then you can do bleaching. And that's when this template comes into place because you can put this against the rubber dam sheet and mark out holes and punch holes for each of these teeth. If you're doing any resin-based restorative dentistry for the lower jaw, upper jaw, not that important, but composite dentistry in the lower jaw without the use of rubber dam is very unpredictable because the variables are so high. As it is, composite dentistry is complicated, very difficult. Each step is important. And if you have saliva contaminating at any point in this, then you're in for trouble. So yeah, if you're doing lower jaw resin-based dentistry, like a class 2 cavity or a class 5 cavity, class 5 maybe you can isolate in other methods, but then at least the class 2 cavity, yeah, you will have to learn how to do quadrant isolation. And once you start getting better and better at quadrant isolation, you can actually go on to, I've seen people do crown preparation under a rubber dam. It's possible. Crown cementation and veneer cementation of all ceramic crowns and veneers are really, really good under a rubber dam because it's a very, very stress-free method of doing this. This is where I can use the rubber dam. So when do I start? Well, there is no time better than the present. The present is the present of previous, let's say 3 months ago, but that doesn't mean that you lose your inquisitiveness. So what I'm giving you today is to allow you to have that little question in your head that why can't I actually start? And when dental companies start opening up with materials, perhaps you can invest in a kit of your own and then start placing the rubber dams. Okay, so that's as far as rubber dam treatment is concerned. We'll move on to the second half of my lecture, which is endodontic access. or how to get from here to there. Now, the most important thing about access is that it's where most mistakes are made. The frequent errors in endodontics are done in access preparation. And that is because I think there is an unnatural hype about access and about endodontics at large. It's not that difficult. You know, we make a big thing about it and we have all these different instruments and techniques which tend to complicate matters quite a bit. But the truth of the matter is endodontics is a very, very simple science. And all it takes is a little bit of understanding, and I don't think it's that complicated. I think restorative dentistry is far more complicated than endodontics. So one way of making sure that your endodontics becomes easy for you is to understand how to prepare a good access and do that every single time you are dealing with a root canal case. The access actually decides whether you're going to be frustrated or not for the rest of the treatment. So moving on, why is access so difficult for us? Why is it suddenly like a big problem? Is it because of lack of knowledge? Is it because of lack of experience? Is it because of lack of time and patience? Maybe because we don't have the right instruments, or maybe we don't know what technique to do. One of the things to be blamed is the dental college. Yes, I guess I have to accept that blame because I teach at a dental college. We don't, or we never used to stress that much on how to do root canals. In that regard, the college where I teach does not have post-graduation right now. So the undergrads are very, very lucky and blessed that way because they have to learn how to do root canal access openings because the patients are coming to the college and there are no PGs to take them away from the interns. So probably there is one mismatch in the colleges today, and stress on endodontics or teaching endodontics is not that great as much as how to do a proper class 2 with an amalgam is concerned. That's all we really learn well. Okay, experience I can understand, okay, because that's something that one has to gain with time. And when you start off, it's difficult as far as experience is concerned. Patience, yeah. Lack of time, endodontics or rubber dam application or whatever it may be in dentistry, it requires a little clear mind and a lot of patience so that you can do the treatment properly. You need to have definitely the right instruments, okay? In my spare time during this COVID lockdown, I've discovered a love for carpentry, and over the last 3 years, I've been buying a lot of instruments. And believe me, if you have the right tools at your hand and disposal, the work becomes really simple. And I actually am not really missing this lockdown very much because I'm enjoying my carpentry, and it is a lot more frustrating than dentistry. But okay, that's as far as the instruments are concerned. The right instruments. You need to have the right instruments, and you'll realize that the moment you have the right instruments, your job becomes a lot easier. The technique is just a modified cavity preparation. So it's not a big thing. You're taking a class 1 cavity or a class 2 cavity and just extending it deeper. That's it. Don't look at it as a big thing. It's not access cavity. It's like a class 1 cavity, but it's much deeper than you're used to. That's all. So have your objectives very, very clear. The reason why you're doing endodontics is because the tooth probably had decay, which led to the pulp. So the problem is not pulpitis or whatever is inside the pulp. The problem is that decay. So the first step is to make sure that the tooth is completely free from decay before you actually start entering into the pulp chamber and seeing what's going on inside over there. Many of the time, what happens is we are so caught up with this concept of access is that we think that root canal, root canal, root canal orifice, root canal orifice, root canal orifice, nothing more than root canal orifice. We are clouded by the fact that we have to find the root canal orifice. That is access. That is not access. That is you being exuberant, nothing else. Okay, so your first objective is to have clear boundaries. Make sure that you've gotten rid of old decay. Make sure you've gotten rid of old fillings. Make sure that the entire space around this particular tooth that you're treating is clear and sterile before you even start. That's step number one. Getting rid of the cause of this particular situation. The cause of the pulpitis was because of an old filling that had secondary decay or primary decay that has reached the pulp. Whatever it may be, get rid of the cause first. That is your first step of access, getting rid of the cause. Second step of access is to visually have a memory of what the chamber outline looks like. Now, this will not come initially that well. Okay, just remember that some part of the pulp chamber always lies below the central fossa. So if you dig into the central fossa, which is over there, if you dig straight down over there, you will reach the pulp, whether you like it or not. The chances of you missing the pulp by making a hole over here, very remote. So don't try and start making the hole over here or on the sides. Your initial access burr hole, try to go for the central fossa because that is a known fact that you cannot go wrong. You will find the pulp underneath there. So when you're starting and you're worried about this outline form that you have to imagine in your head, just go for the central fossa, find the chamber, and then use the chamber to open out the side walls, because once you start seeing the chamber, you will know whether you're cutting too much or just enough. If you are dealing with a vital tooth, then the moment you hit the chamber, there's going to be this fountain of blood that comes up. The problem with having all this bleeding is that it obscures your vision. You can't see what you're doing after that. And the chances of you going wrong are 100%. So your next step is to arrest the bleeding. Take a little bit of cotton, dip it in local anesthetic solution, and just dab it into that hole that you've created and keep doing it till the bleeding reduces or arrests. Stop the bleeding. If you have some like ferric chloride or zinc chloride that you can apply onto the hole that you've created, arrest the bleeding. The moment the bleeding arrests, your vision improves and you can continue what you are doing, which is de-roofing. De-roofing is a term that is used for cutting the roof of the pulp chamber. So the pulp chamber is sitting like this. This entire portion has to be removed so that you can get access into the pulp chamber. That is called the de-roofing. That is your next objective, to de-roof. And finally, clean and debride the chamber. Now, all this while, I did not use the term root canal orifice because access is not to reach the root canal orifice. Get that out of your head. Access is to reach the pulp chamber. The root canal orifices are not running away. They do not have legs. They do not want to move off the moment you reach the pulp chamber. They are always going to be at the bottom of the pulp chamber, whether you like it or not. So don't get too hassled by this concept that you have to find the root canal orifice. That's not the important thing. The purpose of access is for you to reach the pulp chamber and clean out the pulp chamber. If you look at the volume of the root canal, the pulp chamber is much larger than the root canal space. the number of bacteria that is lying inside the pulp chamber is at least like maybe out of 100%, 60% of the bacteria are lying inside the pulp chamber. The rest of it is lying inside the root canal space. So it becomes very important for you to clean out the pulp chamber. And the only way you can clean out the pulp chamber is that if you have accessed into the pulp chamber really well. So access opening is not about getting to the root canal orifices. Get that out of your head. Just think about it in a much simpler way. Access opening is a way for me to reach the pulp chamber. Thus, I reach the pulp chamber, I clean out the pulp chamber, and my access preparation is done. The next step of cleaning and shaping starts after there. That is where you locate the root canal orifice, and you start with coronal shaping and middle third shaping and apical shaping, whatsoever it may be. So this particular slide, please ingrain it into your heads. Access is not to reach the root canal orifices, but to reach the pulp chamber. Very important. Now, no matter how long you train somebody to be brave, you never know if they are or not until something real happens. So, one way to improve your experience is to learn from the dead. The extracted teeth that we have in our clinics, don't let them lie in that sodium hypochlorite solution or hydrogen peroxide solution where they are lying. Take them out, cut them out. Start practicing your access on them. Mount them in POP if you want, and that's your experience. Okay, it may not be as good as learning from the patient, but at least it is something. Don't wait for anybody to tell you how to do it. These teeth will not complain. They will not scream. They will not shout. You can perforate them. You can do whatever you want with them. You will learn from your failures much better. So start from the dead. Okay, that's how you gain your experience when you're beginning. Now, when it comes to root canal access, this is a very, very important step that was told to me by one of my mentors, Dr. C.V.N. Rao. Whenever you're in doubt, don't continue. Postpone it to the first patient the next day or a couple of days later, but the first patient that you see. So if you find that in any point of your treatment, in your access preparation, you're finding it difficult to proceed, instead of proceeding at that particular time, all you have to do is all you have to do is tell the patient, I'm going to see you maybe a day or two later, because an untroubled mind will lead to an untroubled experience. All right. So it's very, very important that you remember this. Okay. It's something very simple and not something really big. But then if you have a problem in endodontics, just follow this principle. It's easy. Now, what are the instruments that you need? The first thing that you need is a clear preoperative X-ray. Okay, a very clear preoperative X-ray. You will be able to observe the pulp chamber size, the location of the pulp horns, and you measure the distance of the pulp horn from the occlusal surface. Okay, usually it's around 6 to 8 mm, and funnily enough, that is the length of your round burr, your normal round burr that you use for cavity preparation. Once it's placed into the area, how much length that you have outside is around 6 to 8 mm, which is a great instrument to use to make your first hole, because you're very safe. You're not going to perforate with that instrument. So you've got your X-ray. The next thing is vision. When you're using a mouth mirror, please make sure that you have something called a front surface mirror. A front surface mirror will make sure that you have unparalleled clarity and there is no ghost image. Okay. Now, if you want to test your mirror, what you have to do is take any probe or pen tip like this and place it against the mirror surface. And if the two tips meet, then you have a front surface mirror. If the two tips do not meet, then you have something called a back surface mirror. Now, back surface mirrors give you what is called a ghost image. And in endodontics, when you're really keenly looking into the mirror, you don't want a ghost image to be seen. Therefore, invest in something known as a front surface mirror. If you look at the other side of a front surface mirror, it will usually have the letters FS imprinted on the metal. Then you know that is a front surface mirror. The next set of instruments are the burrs that you have to use. Now, this is just an indication of what burrs I use. You have the freedom to use whatever burrs you want. When I said the first round burr, I'm talking about this burr. It's a short shank round burr. When you place it inside the air rotor, only about 6 millimeters of it sticks out. So you can use this burr to start with for your endodontic access, your first punch hole. It's great. Now, as I said earlier, endodontics is just the same thing like class 1 or class 2 preparation, except it is deeper. Therefore, all the burrs that you need have a longer shank. That is the hallmark of endodontic burrs. They are much longer than cavity preparation burrs. So you cannot use your cavity preparation burrs for endodontics. You need to really invest in burrs that have long shanks on them. They are much longer than your regular burrs. And there is something known as a safe tip burr, where the tip does not have diamond on it. This is really great for expanding or lateral cutting so that you don't dig in and cause a perforation. This particular burr that I have is only for occlusal reduction, and you can use whatever burr that you want. So these three burrs that you have, these three burrs that you see over here, these are what I use for my initial access. These two burrs that you have over here, I use for lateral preparation or widening the pulp chamber, and this one is for reducing the occlusal surface. The excavator that you use for endodontics is different from the excavator that you have for conservative dentistry. Again, as I said, you need to go much deeper. So you need to find something called a long shank excavator. These are much longer, and the spoon tip at the end is much tinier. You don't need a big spoon, you need a very, very tiny spoon so that you can go into the pulp chamber and scoop out the debris from there. Then the other instrument, which is very, very important for you to have, is something known as the DG16, otherwise known as the Endodontic Explorer. How is it different from your regular straight probe? One, this length is much more, the point is much sharper, and you get one side is a little bit of a contra angle for accessing posterior teeth really well. So that's the advantage of this particular instrument, and this is something that you cannot do without if you want to practice endodontics. So I would suggest all of you, please invest in these instruments, the right burrs, the endodontic excavator, as well as the DG16. The outline you can get from any textbook, so I'm not going to really harp on it. This is something that you have to learn only by experience. You have to start doing it, because no matter how much you stare at a textbook and see these pictures, it does not translate into the actual outline form that you will be doing on the individual tooth that you're treating, right? So these pictures that you see here are just indicative that, okay, for a central incisor, upper central incisor, the access cavity is going to be near the cingulum area. For the premolars, it's more or less central. For the lower premolar, it's again towards the lingual side. For the upper molar, it is towards the mesial side, and for the lower molar, again, it is towards the mesial surface. So this is something that you have to just sort of, when you start cutting up extracted teeth, that is when you will know it. Okay. The next step is entry, as in your first step. So if you're dealing with, let's say, a class 2 cavity, then as I said earlier, your first step is to remove the decay. Okay, so start from the decay and keep on removing the decay. Now remember this, if a particular tooth has become symptomatic because of secondary decay, that means this decay has reached the pulp chamber at some place. Yeah, yeah. So all you have to do is remove the decay and you will find the entry point into the pulp chamber. So you don't have to worry about, okay, I should go from the central fossa. No, if you have decay, it's actually a huge advantage for you for your access preparation, because all you have to do is start remove the decay. Remove the decay slowly, and once you have removed the decay, you will find the pulp chamber automatically, because that will be the point where the decay has touched the pulp chamber. And then take one of these burrs and then make a punch hole, and then from there, based on your idea of how the pulp chamber should be, start extending. So that is an entry technique, which is very, very simple. If you have a class 1 decay, or in fact, anytime you have decay, just follow the same principle. If you have secondary decay under a cavity, under an already filled restoration, excuse me, also very simple. Just remove that restoration, you will find the point of entry into the pulp chamber. So access opening, your initial entry, although we say that you should go from the central fossa, that's an easy way to go, yes. But if you have decay already present, then use the decay. Use the decay as a guide. Take a round burr and keep on scouting around in that area. You will find a drop into the pulp chamber. Once you have reached the pulp chamber, this is where it becomes very, very crucial. You do not want to touch the floor of the cavity. If you have long shank burrs, they are long enough to reach from the roof all the way down to the floor. And this is where mistakes happen. If you have a burr that is cutting on the bottom, so that's where you shift to a safe tip burr like this one, not this one. This one that you have has a non-end cutting burr, the safe tip. This will ensure that you do not dig apically into the floor of the chamber, and you can restrict yourself to lateral cutting. So you have to widen it this way, not apically, just widen it laterally, either buccally or lingually, mesially, distally, whichever way, whichever direction that you have to follow. You're widening the initial cut that you have made so that you can appreciate the pulp chamber better. And remember, you're not looking for the root canal orifices. You are looking to clear out the pulp chamber only. Once you have done your lateral preparation, you switch to your endodontic excavator and scoop out what is there inside the chamber. Do not use a burr at this point in time, because you will unnecessarily remove a lot of dentine than you should be removing. Okay, so in the beginning, I would suggest that you make the punch hole, widen it just wide enough so that your endodontic excavator can go inside. Place the endodontic excavator inside and turn it around, churn it around a couple of times, and feel with the endodontic excavator for the side walls, and then start cutting with the burr. Removing the roof of the chamber is probably going to take you the longest time, and it is the most crucial part of endodontic access, because you don't want to cut too much of dentine, you don't want to cut too little dentine, you do not want to cut apically into the floor of the chamber. So go slow, cut laterally. If you have a doubt, take the excavator, put it inside the chamber, and just feel around. You'll feel the floor, you'll feel the side walls, you'll know where you are, you'll know how much more you have to cut. If you are very, very doubtful, then what you can do is just keep the excavator inside and just take an X and see where the instrument is lying and how much whether you need to remove the roof of the chamber. And finally, once your pulp chamber is completely clean and free of debris, then finding the root canals orifices is not that difficult, because more often than not, they're staring at you at the bottom of the pulp chamber. And take your DG16 and just feel the bottom of the chamber, and you will find places where the DG16 probe just dips into the orifice. And then you will be able to find the orifices of the root canal. So it's not this point which is really important, but all the steps before, starting from removal of decay to removal of all the debris which is inside the pulp chamber to widening the pulp chamber adequately. Those are the important steps in access. Sometimes your access or your pulp chamber can get blocked and you don't really see what is inside because of pulp stones. Now these pulp stones can be seen on an X-ray as calcified areas, calcified little spots, blobs inside the chamber. So when you see that on your X-ray, just be prepared for it. Be prepared. You will, once you open out the pulp chamber, you will not be able to see the floor, because the floor will be covered by this large calcified mass. So you will have to take your excavator and gently pry it out of there, break it up into bits, and then take it out. Once the calcification is outside, then you will be able to see the floor. And as you can see at this picture, the canal orifices are there. You can see it. Still, the chamber needs to be cleaned out so that you can appreciate the canal orifices better. But even just at this point, the canal orifices are present just by removing the pulp stone. Sometimes with older patients, you have calcified orifices. Now, calcifications occur more in the coronal portion of the root canal rather than the middle of the apical third. So the coronal third is where you will find a lot of calcification taking place. There will be displacement of the orifice slightly. I would suggest that if you get a case like this, don't try to do it at one go. You have the option of sending it to a specialist, yes, but if you really want to use this patient as a learning experience, then maybe take 2 visits for your access opening, maybe even 3 visits for your access opening, because you have to understand that treating patients with calcified orifices is difficult, because all your landmarks that are normally there disappear. You uncover the pulp chamber and the bottom of the floor of the chamber is one color. You can't make out where the orifices are, and you have to take multiple x-rays, take your DG16 and keep on sounding, like pressing it against the floor of the chamber to see where probably there is a dip, and then you will have to go in with a micro opener or very, very fine files like a 10 size or a 6 or an 8 size file and see whether you can get this. This is a little advanced technique, okay? So at the beginning, if you're doubtful, please just call in a specialist to do this. But what I would suggest is most of your extracted teeth, if you have them for a long time, they will develop some sort of calcification. So they are really good teeth for you to learn how to remove calcifications and find orifices that have been calcified. So use your extracted teeth that have been lying around for some time. They're a good help. Now, we all know about this thing called the second or the MB2 canal for the upper molars. And if there is a slight modification of the axis, is just widening the axis in one area, which is here. Your normal axis would be a triangular space, but in this particular portion, you have to widen it. It's like an inlay preparation where there is an outward flare from the floor to the occlusal surface. So you widen one side alone, which allows you better vision to see the second mesiobuccal canal. Lower incisors, funnily enough, the way to do access preparation is from the labial side. When you do access preparation from the labial side, you can get a straight line access into the root canals of lower incisors, especially when you are dealing with lower incisors with two root canals. This technique is very, very good. Now you may be thinking, if I do that, would it be an aesthetic problem? Not really. You're going to replace this with either a crown or a composite filling. Make sure that the composite filling looks like a laminate, and it's fine. You can get away with this. But believe me, if you try doing this, the lingual, the labial access for lower central incisors, you will find that it's a lot easier to do the root canals with this kind of access. As you get better and better with endodontics, yes, there is always a need to move on to magnification. Either it is loops or microscopes, expensive, yes. But when you are doing access under such high magnification, you can actually get away with access like this. And as you can see, the center portion of the roof of the chamber is left as is. Access has been reached into the mesial canals as well as the distal canal. This is even more conservative. It's just a tiny hole on the mesial side. Lower molar has reached the mesiolingual mesiobuccal, and another little wider hole on the distal side to reach the distal buccal and distal lingual canals. Now, these are highly advanced access preparations, and I just placed it there to instigate you that once you do your access properly, maybe we can reach up to this point. Now, the only reason why somebody would want to make access preparations like this today is that we have begun to realize that the structure of the tooth is really dependent on the remaining dentine. So access preparation is quite violent. You remove a lot of dentine. And today we are thinking that if we can reduce the amount of dentine destruction during access preparation, the longevity of this tooth post root canal increases. And that is why people are doing access like this. You'll also notice that the clamp that is used over here is a wingless clamp. I mean, this is what a wingless clamp looks like. Okay. This particular journal article, Minimally Invasive Endodontics, is a good thing to read. And anyway, we don't have anything else to do better right now. So just type out these keywords, Minimally Invasive Endodontics, a review, and you'll find an article which talks about endodontic access and how endodontics has evolved to today's in today's world. This is a good reading material for you. And for those of you who are interested in buying rubber dam sheets, this is a website, ident.in, which has the really nice rubber dam sheets. You can feel, I've just placed over there in case you're interested. And if you go to YouTube and type the dental center, then you will find my educational YouTube channel, where apart from rubber dam application, I also have placed a few videos on curing lights, on composite treatment, which for a practicing dentist, it might be useful. So I guess that is it from me today, and I will stop at this point in time and throw the floor open for any questions that you might have. I'm ready to take them. You can use the chat on Zoom, or you can also talk to me, whichever way. But I'm ready for your questions right now. Okay, we have a question on, sir, will you show us how to apply dam for multiple adjacent teeth? We will get to that. We have another question. In minimally invasive prep under magnification, the chamber is removed completely. Now, that is a question that bothers everybody who does not practice minimally invasive preparations. And the only way to do that is to have specially modified instruments that can reach into the nooks and crannies of the root canal space, as well as using a lot of ultrasonically activated irrigation to help chemically remove the pulp. Now, how far this is effective in completely removing the pulp is anybody's guess. So I guess only time will tell whether the people who are doing these ninja accesses or truss access preparations will continue to do that if they see um, failures in their practice. I guess that's the same thing. If we're doing access conservatively, will deroofing be proper? The same question, and therefore more or less the same answer. When you are doing a minimally invasive access, there are a couple of more instruments that you need to have in your armamentarium. Definitely, you will need to have some form of ultrasonic activation and the chemicals that are required to debride the pulp chamber without you actually opening the roof and seeing everything inside the pulp chamber. I hope I've answered that. I will, maybe I could do a little demo on multiple tooth isolation. Of course, it is there on my YouTube channel, how to do multiple tooth isolation. But then, since we have some time over here, if it's okay, we will I'll just show you a demo on multiple tooth isolation. We have another question over here. Can you show maxillary tooth clamp placement? Okay, now this is very, very simple to understand. When you're dealing with the mandibular, or whether you're dealing with mandibular or maxillary, just remember this. This is the bow of the clamp. The bow of the clamp should always face towards the distal side of the jaw. So if it was a maxillary tooth, you would be placing it like this in the exact opposite direction as you would for the mandibular. Just remember that this bow of the clamp always has to be posterior. All right. Thank you, Dr. Balagopal, for those kind words. All right. Right. So we're just going to do a quickly, I will show you how to do multiple tooth isolation. I'm going to take my template. I'm going to place it against this, and I'm going to just mark out. So I'm going to do, let's say from 3.6 to, if I'm doing a class 2 on 3.6, and I would like to isolate up to 3.3. And so I've made the holes based on what the template has shown me. I take my punch.
Sir.
Yeah.
Yeah, the bandwidth is low. Can you please slow down a little bit?
Yeah, I will. Sorry. Okay. So what I'm doing right now is I'm just punching multiple holes into the rubber dam. I have already marked the holes with a template that I had. And okay, so there you have it. Just going to widen the holes for the molars, the tooth that I'm treating. If you are treating let's say if you want to do a class 2 for 3.6, then you have to go at least one tooth behind. So starting from a 3.7 and then isolate all the way down to the 3.3. And what I've done is I've made a series of holes that are according to the template. This is 3.7, 3.6, 3.5, 3.4, 3.3, and one for luck. Okay, so I'm going to place the clamp in the same way. Okay. All right, and lock it so that the lock falls down. Go over the 3.7 and release. Okay. Your next steps would be to isolate the rubber dam. Oops, sorry, two entire tooth came out. But yeah, so you have to manipulate the rubber dam so that you go over each tooth, use floss and go through. Very difficult to do it with one hand on a model, but okay. And I hope you get the idea of what is happening over here. Basically, each hole that you've created goes around each tooth and you can isolate all the way to the front. And what you can do to make sure that the rubber dam stays over there is just cut a piece from this corner and use it like a piece of floss in between, and it stays over there. I'm going to sort of angle this into what I'm doing over here. So it's easier for me to sort of show you from this position. Basically what I'm doing is I'm isolating each tooth, taking the floss and flossing in between. Okay, like so. And hold on, let me get a scissor. Okay, so what I do is just cut a piece of this rubber dam material, roll it up, stretch it, place it in between, and release it. If it is not tight enough, you can do a double fold like this. Sorry, you can just do a double fold and stretch, pass it through, release. So now you've got an idea of multiple tooth isolation. Okay. So I hope this answers that question on how to do multiple tooth isolation. Any other questions? Is that good enough? The anonymous attendee who asked me this question, can you say, give me a thumbs up or say yes or something like that? Are we good?
Yes, sir, it's fine.
Okay, super. There's another question on how to apply, how to put a rubber dam if you're using a wingless clamp. Okay, it's not that difficult really. All right, so what I have here is a wingless clamp as opposed to what I have here earlier. Okay. Now, if you see this and this comparatively, this is a wingless clamp. This is a winged clamp. It has these little winged extensions. This is a wingless clamp. Now, how do we use a wingless clamp? You cannot use a wingless clamp with the frame attached to it. It becomes very, very difficult. So what you have to do is just take the wingless clamp and pass it through the hole like so, okay, so that the bow is exposed through the hole. All right, now lift the rubber dam like this and put the forceps into the wingless clamp, lock it in place, and then so with it lifted, you have to place it over the tooth, release it, then fold it over, and then take an instrument and release one side, release the other side. Oops, sorry, I tore it. Basically, yeah. You release both sides, and that's how it's done for a wingless clamp. Is that okay? What is the dilution of sodium hypochlorite? But 5.25% is great. I prefer dropping it into the pulp chamber and allowing it to work. A good friend of mine, my colleague, Dr. Siju Jacob, gave me the suggestion of leaving sodium hypochlorite inside the pulp chamber and walking around for 5 minutes and then coming back to treat the patient. By the time you've allowed the sodium hypochlorite to actually work on the pulp tissue. So, all right, how can we afford the big, how can we put the big frame in the patient's mouth? Now, okay, fine. The frame actually doesn't go into the patient's mouth. It's always going to be sitting outside, okay? So whether you're using the plastic frame or whether you're using the metal frame, it's just going to be sitting outside. So you don't have to worry too much about the patient's mouth size. That's not an issue. Are there any other questions that somebody might have? How about multiple teeth with a missing tooth in between? Do we use two clamps? It's up to you. Okay, let me see. if I have a situation like this with a missing tooth in between, then I can I can have the clamp around, let's say, around the second molar on one side, like this. And over here, I can choose to place a premolar clamp or an anterior clamp. Take a piece of rubber dam material and over here. In the center over here, if you want to just snip it, cut it with a scissor, you get what is known as a split dam. So instead of having punching separate holes, you punch one hole for the tooth behind, one hole for the tooth in front, and then just cut the rubber dam in the center between this and there. It kind of flops down onto the side. Here you will need some kind of chemical isolating methods like opal dam or some other liquid dam to seal the edges of the split dam that you've cut. Okay, does that answer that question?
Sir, we don't have more questions, I think.
Okay, great.
Can we move to the wind up section?
Sure.
Okay. Thank you so much, sir. I invite our secretary, Dr. Sanal Babu, to share a few words.
Good evening, Dr. Yohan sir, and all of the participants. I am Dr. Sanal, ID Ernad Branch Secretary. It was a wonderful webinar on topic PPA, personally protected assets. And the presentation was excellent. You have demonstrated the things very well. Very well. You have demonstrated all the things. And you have provided so many ideas to our members about the rubber dam and access opening.
Thank you.
And hope it will be applying in their daily practice. First of all, I would like to thank all the participants, those who made this program a big success. On behalf of ID Ernad branch, I really appreciate and thankful to Dr. Yohan for being our faculty. Special thanks to Dr. Sabish, Dr. Shyam, and Dr. Rose for the support. Dedication your presentation, especially the demonstration. Awesome. Thank you so much, sir.
Thank you, Dr. Sarma.
Thank you, sir. I have shared that memento for you. You can see in this screen. Thank you so much.
I've taken a screenshot of it. Thank you so much.
No, I'll send you, sir. I'll mail you.
I mean, this is really. I mean, it's redefining continuing dental education. This whole sitting at home and conducting webinars. It's a good thing.
Yeah. Thank you, sir. Have a nice day. We are winding up. Thank you all.
Okay, thank you all. Bye-bye. Have a nice.
Bye-bye.